Mr. Quigley, Mr. Davis. You are recognized, sir, for 5 minutes.
Thank you very much, Mr. Chairman. Although estimates vary, research on the prevalence of autism spectrum disorders suggests that black and white children are impacted at comparable rates, with lower incidences observed among Latino children. Is there consensus on this data?
You are correct. So our most recent data shows that the prevalence among African American children and white children is fairly comparable. The Hispanic, the Latinos, are lower.
Is it possible that lower rates among Latino children reflect a lack of awareness within the community, and that might be the reason?
That could be the case. And the program I was talking about earlier, which was Learn the Signs, Act Early, we're actually trying to target Latino, Hispanic populations, working with our state colleagues. We have all of our materials translated into Spanish specifically to try to do that. So we are, within the context of the work we're doing, really trying to impact that.
Dr. Goodmark, are you in agreement with?
I'm in agreement and would bow to Dr. Boyle and the CDC for their expertise in this.
It has been suggested that children can be diagnosed as early as 14 months old, giving those children and their families the benefit of early intervention and treatment. However, children of color are routinely diagnosed at a later age than their white counterparts. What barriers exist to early diagnosis of all children, and are there any socioeconomic barriers that prevent parents or physicians from recognizing the early signs of autism among children of color?
I think there are issues of access to quality care, having access to longitudinal care, for instance. The pediatrician or family physician who sees a child, the same provider seeing the same child over time, can more easily pick up lack of appropriate developmental progress, et cetera, than a physician who is, or other healthcare provider who's seeing the child only for episodic care. So I think some of the questions of access, et cetera, no question, for diagnosis is principally made in a medical context. There are issues of access here.
So if a family did not have, say, primary care physicians for both themselves and their children, then it is possible that there might be a later diagnosis than if they had this ongoing care all along.
I think it's possible. It creates, this is, there are obviously many challenges to making this diagnosis earlier would have happened long ago. And this adds, I think, to the challenges for the family, for the healthcare providers in doing that.
Well, let me ask this question. Once diagnosed, individuals with autism spectrum disorders have average medical expenditures between 4 and 6 times greater than the rest of the population. The Harvard School of Public Health has estimated that it can cost $3.2 million to care for an individual with autism over the course of a lifetime. Although insurance covers some of these costs, intensive behavior therapies, often paid out of pocket, can cost as much as $60,000 per year. For families of average or limited means, that means that limited access will also occur to treatment. What level of access do low-income children have to behavior or therapeutic interventions before they reach school age?
That varies by locale, certainly to some degree, in terms of what provisions are based in the community and their level of availability. No question that for any family, even a family of great means, the challenges of appropriately caring for a child with autism are financial challenges along with the other challenges they represent. For those of lesser means, clearly the financial impact can be even relatively greater.
Are we making any real progress with that issue?
I think we're making progress. Again, it's frustratingly slow, but we're making progress in terms of coming up with more interventions that make a difference. And ideally, one wants to have an array of options for interventions, because different interventions will be more successful for one individual, for one family than another, but also that access to them will vary, so that it's one of the reasons for not saying, gee, we're happy we have interventions, but say instead, well, we've made progress with interventions, but we clearly need to develop more.
Thank you very much. I yield back, Mr. Chairman.
Thank the gentleman. Now the gentleman from Florida, Mr. Posey.
Thank you very much, Mr. Chairman. Dr. Boyle, my predecessor, Congressman Weldon, was a well-respected, competent medical doctor, and a great deal of esoteric expertise on this subject that I'll probably never have. But I gleaned from him some certainty that he felt thimerosal in vaccinations definitely was a contributing factor to autism. And I read not very long ago an article that had said until the wonderful people like us introduced vaccinations to Africa, the African children basically were autism-free. They never heard of autism, never had a case of Down. Are you familiar with that? Have you ever heard that before? Okay. I wonder if the CDC has conducted or facilitated a study comparing vaccinated children with unvaccinated children yet. Have you done that?
We have actually done a number of studies looking at the relationship between thimerosal vaccines and autism and other developmental disabilities. And there have been, since actually over the last decade, there have been numerous studies looking at the relationship between vaccines and aspects.
That the CDC conducted?
Some of them were conducted by the CDC, others were conducted by
How many would you say? Would you estimate?
I would actually have to check what the specific numbers, but I know there were two. One large study looking at various neurodevelopmental disorders, and the second one that would focus specifically on autism. And those were fairly recent studies.
Would you see that my office gets a copy of those, please?
Of course.
Do you believe additional study would provide useful data in assessing the safety of childhood vaccines?
The IOM has evaluated this issue back in 2004 and again most recently in 2011. And their conclusion, again, was not just looking at the work that was done at CDC, but with the total body of evidence, was suggesting that vaccines and their components did not increase the risk for autism.
My time is very limited here. So clearly, definitely, unequivocally, you have studied vaccinated versus unvaccinated.
We have not studied vaccinated versus unvaccinated.
Oh, okay. Never mind. Just stop there. That was the meaning of my question. You wasted 2 minutes of my time. What steps has the CDC undertaken to ensure the integrity of the research that was performed by Dr. Thorson, who, as you know, has been indicted for misconduct and misallocation of resources?
So Dr. Thorson, who was a co-investigator on a couple of studies that came out on autism, was really just one investigator. And that body of evidence related to vaccines and autism.
All right. Have you gone back to validate the variety of studies he participated in? I mean, this guy is a humongous scumbag, one of the most wanted men on earth. And you relied upon him for data to determine whether thimerosal had a negative effect?
So two studies don't don't conclude a body of work. The body of work that's relating vaccines to autism is a large
I know,
collection
but
of studies.
you told me you only had 2 studies relating to vaccines, vaccinated and unvaccinated, so you must figure 2 studies must have some weight. Running out of time quickly here.